All right, Airway Management Part Two. In Part One, we talked about the importance of the anatomy and physiology of the airway, as well as being able to maintain its patency using the head tilt chin lift or the jaw thrust maneuver, and then some simple adjuncts that you could use to include an oropharyngeal airway and a nasopharyngeal airway. Now we're going to look at things like suctioning and then keeping the airway open with definitive care. Other adjuncts that may be available to you as an EMT, as well as some special considerations, particularly in the pediatric patient. Now, there's going to be times where inside the mouth you're going to find obvious liquids, whether they be blood, secretions, vomitus, and they're going to have to be removed from the airway so that those liquids aren't aspirated into the lungs or sucked into the lungs. Even a small amount of liquid, as little as a teaspoon, can cause a pneumonitis, which can lead to a pneumonia, which in some people could be life-threatening. You can use a vacuum device or a suction device to remove liquids from the airway. And there are different types of suction devices out there. There's the mounted suction systems that you'll see in the back of the ambulances or mounted on the walls in hospital emergency departments. They're able to furnish air intake of at least 30 liters per minute and generate a vacuum no less than 300 millimeters of mercury. You'll notice when doing your clinical and ride, you can adjust the millimeters of mercury of suction that the suction unit provides, but typically 300 is what you want for an adult. That may be a little too much for smaller children. There are also portable suction units, and they have to have the same requirements or meet the same requirements as the mounted units. They could be oxygen or air powered, or they could be powered by batteries or electricity, or there's even a hand pump, a manual one where you use your hand to provide the suction. Attached to the suction device, you're going to need tubing. You're also going to need tips and catheters to do the suctioning with. And then a collection container to collect whatever it is that you suck out of the patient's mouth, and then a container of clean or sterile water so that you can clean up the suction catheter after use. So here's an example of a mounted wall suction unit in the back of an ambulance. You can see here's the measure the pressure. Here's a little knob that will allow you to adjust the pressure. Here's the suction tubing connected to the canister, and then the suction tubing connected to a rigid Yankauer suction tip. Tubings, tips, and catheters can be rigid pharyngeal suction tips, and they're also called Yankauers. They're also softer, larger bore, flexible catheters as well. And when using a Yankauer suction tip, you want to measure it much like you do an oropharyngeal airway because you don't want to place it too deep into the back of the throat, particularly in a patient who may have a gag reflex. And on the tip, there is an opening that you don't cover while you're putting the tip into the mouth. But once the tip is placed in the back of the throat, you occlude the opening with your thumb or finger. That applies suction, and you move the catheter back and forth as you work it out of the mouth. So suction only as far as you can see. Don't lose sight of the distal end, and you can prevent that by measuring it first. And careful insertion will help prevent a gag reflex or vagal stimulation. When you start poking around the back of the throat, you stimulate the vagus nerve. And when the vagus nerve, which is the 10th cranial nerve, when it is stimulated, it releases a hormone called acetylcholine. And acetylcholine slows the heart rate down. So the longer you suction, the more likely it is that you're going to cause a very slow heart rate in your patient. Now, flexible suction catheters are designed to be used when you can't use a rigid tip, like through the nose or through a endotracheal tube, and they can be used for suctioning the nasopharynx as well. The flexible suction catheters, just like the nasopharyngeal catheters, come in various sizes identified by a a number French, like an 18 French or a 20 French or a 16 French. The larger the number, the larger the catheter. Flexible suction catheters are not typically large enough to get a lot of really thick secretions. The flexible catheters may kink as you insert them. If you've got a lot of copious thick secretions, just try using the large bore rigid suction tubing that the soft suction catheter is attached to. You're going to measure it again like you would an OPA. The length of the catheter should be inserted into the patient's mouth. Again, not losing sight of it. Here they are measuring it. You wouldn't want to stick it in any further than that. You want to wear personal protective equipment whenever doing suctioning because the patient could cough, vomit, and spray your face as well as get it all over your hands. So you want to wear eyewear, mask, and disposable gloves. You want to position yourself at the patient's head, turn the patient's head to the side so that if they do vomit, it decreases their risk of aspiration. You want to check your equipment to make sure that it's functioning well. You want to suction no longer than 10 seconds at a time. Prolonged suctioning can cause hypoxia, and if you stimulate that vagus nerve enough, can cause bradycardia. If the patient vomits for longer than 10 seconds, you're going to have to suction longer than 10 seconds. The important part here is that just keep in mind that as a general rule, we suction no longer than 10 seconds, but we suction till clear. It doesn't do us any good to suction half of it out and then ventilate them with a bag valve mask or have them risk aspirating that themselves. So you have to suction till clear it sometimes, and that may be longer than 10 seconds. You want to place the tip or the catheter where you want to begin suctioning and suction only on the way out. As far as definitive care goes with keeping the airway open, it may exceed your capabilities as a basic EMT. There may be the need for medications for rapid sequence airway. There may be a need for surgical procedures like a needle or surgical cricothyrotomy in order to remove potential airway obstruction. So as a result, if managing the airway requires something beyond your scope, that certainly indicates the importance of calling for paramedic assist. You want to rapidly evaluate and treat airway problems as soon as possible. If the airway becomes obstructed, the patient will not get enough oxygen and may essentially die. And then again, recognize your limits and may call for an ALS intercept or take the patient quickly to the closest hospital. If you're not able to manage the airway at a basic level, the advanced resources that might be available to you would include, removing a foreign body with McGill forceps and a laryngoscope, rapid sequence airway where medications are used to sedate and paralyze a patient, and a more advanced airway is placed like a endotracheal tube, and if the airway is completely obstructed, the upper airway is completely obstructed, then accessing the lower airway through a needle cricothyrotomy or a surgical cricothyrotomy would be something that paramedics could do. Now, when you're dealing with a patient who has severe maxillofacial injuries, that is going to cause severe swelling and bleeding that may block or partially obstruct the airway. So be aware of that, and perhaps, if possible, place those airways before it becomes too late. Bleeding may also require more frequent suctioning to keep the airway clear. Remember that suction units are not adequate for removing solid objects or big chunks, so you may have to remove those with manual techniques. If somebody has a foreign body airway obstruction, certainly doing abdominal thrusts if they're conscious, chest thrusts, and finger sweeps as appropriate. If a person has dentures, as long as they're in there nice and tight, you can leave them in place But if the dentures become dislodged or they're loose, they need to be removed and set aside and make sure they go with the patient. Now, as far as children go, there are a variety of anatomical differences when dealing with children that affect our ability to manage their airway. They have a much smaller mouth and nose, so it doesn't take a lot to obstruct their airway. They have a much larger tongue, so it is more likely in an unconscious child lying flat on their back to have an airway obstruction from the tongue. Their trachea is a lot narrower, more flexible. It can collapse easier because the cartilage bands aren't very formed. Because it is so narrow, it doesn't take much to obstruct it at all. The other thing to consider is that when you lie a child flat, particularly a younger child, their head, the back part of their head, their occiput, may cause them to be hyperflexed. Their chin may be more closer to their chest, and that may obstruct their airway just lying them back. When managing the airway of a child, open their airway gently. Don't hyperextend the neck. To know that a child's airway is open, we look at the pinna of the ear. It should point to the shoulder. If we hyperextend the head, the pinna will point up. And if they are hyperflexed because of their large head, flexing their head forward, the pinna will point down. So you look at that, or look at that part of the ear. Excuse me, I said pinna. It was tragus. Look at the tragus. The tragus should point right at the shoulder. That's how you know the airway is aligned properly. Consider adjuncts when other measures fail and you have both nasopharyngeal airway and oropharyngeal airways that will fit children. You can use rigid tip suctioning, but don't touch the back of the airway on a child. They're more sensitive to stimulation of their vagal nerve, and hypoxia, in addition to stimulating the vagus nerve, causes severe bradycardia in children, which may drop their blood pressure and cause them to go into cardiac arrest. So we identified that the airway is the passage by which air enters the body during respiration and breathing, and that you can't survive without an open airway. And as an EMT, it's going to be your responsibility to make certain that the airway is open, and if not, suction where necessary, position the airway where necessary, and also use adjuncts like an oropharyngeal or a nasopharyngeal airway to help you keep that airway open. Again, it may be necessary for you to suction the airway using either manual techniques to remove fluids and solids from the airway before, during, and after artificial ventilation. In other words, if you're ventilating the patient, you may have to suction and remove stuff prior to doing that. Always use personal protective equipment when suctioning and managing the airway because of the potential vomiting, spitting, coughing, and getting stuff in your eyes and in your mouth. Remember that airway assessment is a dynamic process. You don't just do it once. You assess it over and over again to make sure that the airway remains open and patent. And airway management should start with the simplest stuff first, like position, suctioning, and then become more complicated only if necessary, like adding the oropharyngeal airway or adding ALS for a more advanced airway. All right, so that ends part 2, a little short discussion of airway management. And if you've got questions, you know how to get a hold of me, and I'll talk to you soon.